So here we have an arthroscopic menisectomy in a right knee. There's been a previous meniscal repair. However, this is unfortunately not healed and the patient remains symptomatic with mechanical symptoms. This is developing the medial portal, finding the soft spot, and subsequently inserting a 11 blade under direct vision, being very careful to penetrate the capsule with the tip of the blade, and then make the capsular incision large enough that the arthroscopic instruments and any meniscal pieces can be taken back and forth through it, whilst not penetrating too deep and cutting the articular surface with the sharp pointed end of the blade. Then an arthroscopic probe is inserted to ascertain the extent of the tear, and here you can see the rolled edge of the meniscal tear underneath the edge of the tibial plateau, and the probe is inserted and used to flick this rolled piece of meniscus back out. Very easy to miss these small fragments that have rolled and tucked underneath the edge of the tibial plateau unless you use the probe to check for them. Here you can see probing the posterior horn of the meniscus in the central part, and it's clearly very unstable, split in the middle, all the way from that junction of middle third and posterior third all the way to the back. The patient's had a previous ACL reconstruction, and you can see that the graft is ligamenticized nicely there, with the vascularity running all the way up along its length. Moving over to check the lateral compartment, placing the leg up into figure of 4, dropping over the anterior horn of the lateral meniscus, a little bit of synovial fluid which is clouding the picture, which is allowed to escape from the knee. And then on reinsertion the picture is much clearer. The lateral meniscus is probed, it looks absolutely pristine, no evidence of any instability or a tear. Then coming back across in front of the ACL reconstruction and into the medial compartment again. Initially a duckbill angled slightly to the right is inserted. This is taken down towards the very anterior aspect of the torn section, trying to give a nice clean start to the menisectomy, running it in onto the meniscus, dividing that small free fragment which was rolled underneath the tibial plateau, biting it almost till it's completely detached, and then inserting a ratcheted arthroscopic grasper, and that's used to remove the small piece of meniscus. Again, getting a nice bite of the entire section, trying to remove it in one go, but as you can see here, it didn't come out with the instrument, so I've looked back, turned the water off at this stage so it doesn't float away inside the knee, and then reinserted the grasper, again trying to keep the fragment in the view at all times with the water off so that it doesn't dive off away from you, and grabbing and removing that from the knee. Then reinserting the arthroscopic probe to again ascertain where the rest of the meniscus should be trimmed from. You can see the sutures from the previous meniscal repair, which is unfortunately not healed, not holding the meniscus down, and from around about that point where the probe is now all the way to the posterior horn is unstable. Therefore again the right sided duckbill is reinserted. And the menisectomy will be commenced from the anterior aspect, trying to detach the unstable piece of the meniscus, leaving the healthy anterior horn alone. So here you can see the duckbill coming in just in front of where that meniscal suture is, and as soon as it's just captured that corner that's unstable, you can see the meniscus folding away from you, the unstable section gone. Then initially taking the posterior horn attachment now, switching to a straight duckbill so it gives us a cleaner cut, and then taking small bites of that posterior horn as it attaches onto the posterior root, trying to leave as small a tag as possible and contour it towards the back of the knee. And again, just dividing that up to the point where it comes free, but not quite through it. Again, it doesn't float away through the knee. And having done that, the ratcheted arthroscopic grasper can be reinserted, moving the debris out of the way to get a clean bite of this section. You can see how friable the meniscal tissue is as it comes off in the grasper. But once there's a solid bite of that posterior horn section, that can be removed as one piece from the knee. The arthroscopic shaver is then inserted. This is a 4.5 incisor, and that's used just to clear the debris, to make the edge of the menisectomy nice and neat, using that to contour this little tag at the posterior horn, which, if it's left too large, can cause mechanical symptoms. And it can flick back and forwards right at the back and cause painful catching. Once that's contoured, running the shaver around the anterior aspect, just making sure that piece of meniscal suture is gone, smoothing down any free edges. You don't want anything left that's going to be catching or tagging, especially moving around within the joint or catching around that edge of the tibial plateau. And here, again, just trying to smooth down that back corner. And it's always a bit of a balance between taking it completely and leaving a small tag. Clearly this is a large posterior meniscectomy, and if the patient were to experience symptoms following that and meniscal replacement surgery was considered, then if a synthetic meniscus was to be used, then an anchor point is necessary, and so you don't want to remove all of this root. However, you don't want any unstable tissue back there or anything that would be catching and irritating. Finally, again, just reinserting the shaver, again taking that edge down a little bit, making sure there's nothing loose, making sure there's no debris floating around within the knee, and then the arthroscopic probe is reinserted just to probe the remainder of the meniscal tissue around the rim, just checking that there's nothing flipped underneath towards the edge of the tibial plateau, nothing unstable.